Today we're going to talk, I think it's a good segue from Dr. Olof talking about the renal mass guidelines yesterday. And I think we alluded that there's not much change with partial nephrectomy, but I think this is one of the areas where we are seeing some change as we're getting some long-term data about ablative technology. It's only a 20-minute lecture, so I'm not going to get into the depths of the results of technologies. I'm going to mention them, but I think it's a good segue to cover the whole topic without committing to any one area. All right, ablative techniques. Favored for treatment of small renal masses, less than 3 centimeters is I think the agreement on that. Certainly people that have CKD, multiple tumors, or a solitary kidney, there's a lot of emphasis on trying to push those patients now. And patients with significant comorbidities, and we mentioned yesterday anticoagulation is one of them. Nothing worse than doing a complex partial nephrectomy in somebody with some kind of stroke or heart disease, and the day after surgery they have recurrence of their symptoms, and you're like, do I heparinize them and they bleed to death, or do I let their stroke progress and do nothing? So these are patients that you can avoid these situations by doing different therapy. We now have long-term follow-up for RF and cryo. The contraindications are uncorrected coagulopathy, suitable location to create an ablation zones, and an active UTI. Recommendations of the AUA, just in summary, consider it as an alternative in solid masses less than 3 centimeters. And you look at the three, and they all say the same thing. And as far as today in 2024, all recognize that partial nephrectomy is the preferred and appropriate patient. So that all the societies agree on that right now, but they all recognize there's a role for thermal ablation in the algorithms. This is the ablate planning algorithm. I know it's small, you can't read it, but it goes through all the different situations, and I recommend that you look at it to just get in detail what are the appropriate cases as they've brought out in the algorithm here. So what are the options for ablation? The most common are RF, certainly that was the first one, cryoablation, a microwave. I have to say, looked like RF was getting supplanted, but there's a lot of people going back to it because there are a lot of advantages to it that, the newer technologies aren't always great. I think the two evolving ones that are exciting are Irreversible electroporation and Stereotactic radiotherapy, which is not really ablative, but I think we can put it in the same category, and we're going to touch on those as two that are up and coming. If you look here, where are we now with ablation? And if you look here, this is from the Mayo Clinic, large cohort of nephrectomy, RFA, and cryo. And if you looked at this study, 98% local, 2% local recurrence rate, 98% non-recurrence, if you look at all the treatments, if you include retreatment for the ablative therapies. So I think this shows for selected patient, you can get excellent results, at least in the short term. And with the Mayo Clinic data, it's more than short term. RFA is the initial ablation technique using radiofrequency power, using electrical current energy, coagulation necrosis and cell death after 60 degrees centigrade. And so this is the first one. You can see the characteristic here. You have a lesion, you put the umbrella in, and you get a coagulation zone. The advantage of that is we have extensive data on this. It's a single probe that you just get in the right area with the umbrella. Relatively short treatment times, and it's really low cost. I mean, all you need is the generator and the probe, and there's not much extra special technology you need. You don't need a special tech. You don't need any special equipment. The disadvantage is that you cannot see the kill zone, and I think it's been pretty well worked out. For larger tumors, you do not get a good ablation. You get the charring effect. Once you get to a certain point, you don't get further ablation. You get just charring, which inhibits increasing ablation zone. And for the central tumors with the heat sink effect, you're not getting effective ablation there. If you look here, this is a study from long-term outcomes. And if you look here, you can see here for T1A, local recurrence is 4%. and for T1B, 14% local recurrence, showing its limitations to larger tumors. But if you look, 5 of the 6 that were initial failures were successful with salvage RFA, showing that you can actually get very similar for well-selected results to partial nephrectomy, but it is optimal for exophytic small tumors with non-central location. Wanted to show this here. This is a study I did with Mohammed when we were at Hopkins here. You always put up the names of the people here. And this was one of the first studies with RF. We did 49 patients, and we found the same thing. We had 3 local recurrences, all in large central tumors, so confirming that this does not hold up. Complication, interesting, complication rate is 10%, with nerve injury and urothelial injury being the largest, and surprisingly, bleeding was only 1%. And so if you have somebody that you need to anticoagulate, getting back to what we talked about yesterday, RF is probably your treatment of choice. Cryoablation, argon-based gas, low temperature, coagulative necrosis, less than minus 25 degrees centigrade. And once again, this is a highly effective, reproducible. We have extensive data. You can see the ice ball, which you can get comforted that you're not damaging other structures and you're getting the kill zone in the right place, 3 millimeters inside the ice ball. Safer near the collecting system and with multiple probes is effective for larger tumors. The disadvantages is long treatment time. Multiple probes requires complex setup, higher cost, tech. In our place, we don't own the equipment. We have to rent the equipment to come in. So you get into a lot of complexity, and there's a much higher risk of bleeding, which we'll show. If you look here, this is percutaneous cryoablation for larger tumors. Just wanted to show here that in larger patients, you can get effective cancer control even in larger tumors as opposed to RF ablation. Going back to the same paper I cited before that I think the best for showing the overall complication rate. Overall complication rate with cryoablation is 12%, of which 7.5% of that is bleeding. And so RF has very little bleeding, but other complications. This has a lot more bleeding, but less complications related to nerve injury and to urothelial injury. So kind of pick your poison. If you look at the oncologic outcomes here, this is a graph showing all 3 local recurrence for partial nephrectomy, cryoablation, and RF. And you can see that you're getting excellent cancer control in all 3 cases. Obviously, there's selection biases for each, but you can see you're getting, from a cancer point of view, you're not compromising care. Microwave, this is something that's come out more recently. You get electromagnetic waves greater than 60 degrees, thermal coagulation necrosis. You can see here's an optimal lesion, peripheral, probe in, single probe. The advantage of this is unlike the cryo where you need multiple probes, up to 4 centimeters you can treat with a single probe. Definitely more efficient compared to RFA for quicker treatment times with less heat sink. You don't get the charring that you get with the radiofrequency, so you get faster treatment. And they say potentially larger an endophytic tumor, even though the data has not really borne that out. The disadvantages, it's a less predictable ablation zone. So certainly when you're working close to other structures, colon, ureter, small bowel, you may get inadvertent injury if not careful. And there's less data, even though I'm going to show there's some recent papers showing pretty good results. This is a paper that came out last year, and this is from with McClure. And the important thing you can see here is that they compared microwave to cryoablation and found equivalent results. Local recurrence rate at 5 years was 6% with the cryo and 5% with microwave. So compared to microwave, which is already established, we're finding equivalent results for well-selected tumors. So just to keep that in mind, that this is something that is evolving and may come about. And as I said, the big advantage of the microwave is the ability to just place one probe. I mean, RF is nice, but you need to get the not just the probe, but the umbrella in the right place. With the microwave, you just need to get the probe in the right place. IRE. I think this is something that showed some promise that I have to say, doing a recent literature search, I'm a little disappointed in. It's non-thermal ablation technique, multiple probes placed, creating electric fields between them, leading to apoptotic cell death, and preserves non-cellular tissue within the kill zone. So you can see here, here's a lesion. You get these probes, and you're within these through probes, you're setting up a field that kills the area here. Advantages: low risk for collateral damage, no thermal injury. Once probes placed, there's quick treatment time, so you're not inadvertently injuring healthy tissue. The disadvantages: it's a new technology with minimal data, multiple probes needed to create the field, which is always a big disadvantage. Interpretation of the ablation zone and follow-up imaging is very hard. With the other ablation techniques, we know that we're going to look for the lack of enhancement. We don't know how to follow these patients up. And it requires general anesthesia, but I have to say, in our center, we're using general anesthesia for all of them, just because I think you get a better controlled situation. If you look at the outcome here for a study with Jeff Cadedu, who was one of the senior authors, who's another person that worked with us at Hopkins, 46 tumors, local recurrence rate 13%, but a very steep learning curve, and recommended for use only tumors that are purely central and not candidate for standard percutaneous therapies. So that's where we are there. I'm just trying to check in my time here. Make sure I stay on time. SABR, I think this was mentioned yesterday by Mohammed. I think there is a lot of potential here. This is using radiation therapy, completely non-invasive modality. Initially, renal cell cancers were thought to be relatively radio-resistant. However, new technology allows for highly conformal ablative doses to be delivered. And this is important due to the presence of adjacent radiation-sensitive luminal intestinal organs. So you can see here, this is a renal tumor, and you can see your radiation zone as opposed to other organs around it. It can be delivered in a single or multiple fractions, and obviously there's always a problem with any therapy on the kidney for motion, and in order to counteract that, they have four-dimensional positioning through respiratory phases to create an internal target volume that you're shooting for, but obviously you're always trying to hit the missing target, the moving target. The advantage is it's totally non-invasive, delivery of ablative doses of radiation of greater than 6 gray per fraction. Patients that are best for this are ones that are not eligible for surgical procedures or thermal ablative therapies. But in most cases, you could argue if they're not candidates, maybe they should just be on active surveillance. But we all have patients that are active surveillance, failing, growing tumors that we need treatment, and we worry about treating them due to the risks of the procedure. It has good local control and low toxicity profile. The disadvantages is there's limited short-term data, and precise targeting is a problem because of the moving organs with the kidney with respiration. If you look here, there's a 5-year multi-institutional study, single fraction 81, 109, multiple fractions, mean tumor size 4 centimeters. 75% of these candidates were deemed not operative candidates. So these are patients that are just really high risk for any surgery. And I think the important thing is it's pretty reasonable local recurrence rates, 5.5%. Not quite what you're getting with partial nephrectomy, not quite what you're getting with ablative percutaneous therapies, but certainly acceptable. So if we look here at the graph here, the chart, and if you look, there's no clear winner. You go across cryoablation, efficacy is great, safety is great, works for large central tumors, not an easy learning curve, especially due to multiple probes. Ablation time is a problem. It is very costly due to all of the increased time in the operating room, the CT scanner, cryotherapy equipment. RF is great efficacy, good safety for well-selected cases, not good for large central tumors. Actually, it's pretty easy to learn, single probe, get in the right place. Ablation time is favorable, and cost is very favorable because you don't need any highly specialized techs or equipment. Microwave, I think this is the one that's coming that we'll see a little bit more. It's efficacious, it's safe, can be used for central tumors, easy learning curve, favorable ablation time, and cost-wise is actually pretty good. The two below here, a lot of question marks. You can see IRE. Really, it's not something I would offer as first line because we don't have enough information or data on it, but it certainly does take a lot of time and a steep learning curve. And SABR, I think there's going to be a role for this as we move along. We don't know the long-term efficacy, but it seems okay. Safety seems pretty good. Can be used for large central tumors. Very easy learning curve, especially for us because we refer them to radiation oncology. The disadvantage is going to be the cost. It's going to be a very costly alternative, but for well-selected patients may be worthwhile. So in summary, all three established energy sources, and that would be RF, cryo, and microwave, effective from cancer and safety point of view, and I emphasize in well-selected patients. For RF and cryo, we do have long-term data that really shows good local recurrence results comparable to partial nephrectomy, once again in selected patients. Emerging data for microwave really looks good actually for selected patients, and I think there are patients that are better for microwave but less good for microwave, and each one has its its advantages and disadvantages. IRA and SABR are still investigational, but accumulating data for multiple tumors. But I think the SABR is the one that I'm probably most excited about. Cryoablation does have the advantage of the ice ball visualization. As I move to a new center, most of these I used to do most of them at GW, most of them are done by IR. I always use cryoablation because I always felt more comfortable being able to see exactly what I was doing. And it was interesting. There was one that I didn't see an ice ball, and I questioned the machine even though the temperatures were minus 30. And we actually got no ablation because the machine wasn't working and the sense broke. So, I mean, it was, for me, I knew what I was ablating. In that case, I knew I wasn't ablating anything because I didn't see anything. And so for me, it was important, to be able to see that. There's some advantages with microwave with regard to larger and endophthalmic tumors over RF. Even though if you talk to Jeff Cadedu, who's been doing this as long as anyone, he's still working with RF and very happy with it and pleased with his results. So in conclusion, partial nephrectomy remains the standard for treatment of small renal masses. Definitive diagnosis, because you're excising the whole tumor, and highest primary treatment success rates. And that's unequivocal. Once you put in multiple treatments, you may get similar with ablative therapies. Ablation techniques have been used increasingly with similar functional oncological outcomes, especially with multiple treatments. In elderly and comorbid patients, tumor ablation is a valuable option, but always consider active surveillance. And I raised a question yesterday, I have to think about it. I think we're at the point where if I had a small posterior tumor, posterolateral tumor, would I have Mohammed do my partial nephrectomy? I have to say I would probably get it a biopsy, and if the biopsy was definitive diagnosis, I would get it ablated and go to work the next day. So, as opposed to the morbidity of a big surgery. Thank you very much, and I'm done with 40 seconds to spare.